speaker is Dr. Khalid Saeed. He has a private practice in Baghdad, and he also has done the bird course, the cosmetic program, which is a multi-module program. And he finished his course in Dubai, and he graduated, I believe, this February.
I think Khalid has finished his course. Before that, he done the courses in Iraq.
Iraq, and then he's done
the implant and the cosmetic in Iraq as well. But he came back to help us in the course in Dubai with his fiance. Khalid, are you with us?
Hi, Dr. Hassan. Yes, I'm with you.
Hi. You need to start your video, my friend.
Start the presentation? Start the video.
No, the video at the bottom next to the mic. Excellent. So we can see you. Excellent.
So you're going to talk to us about the minimum preps today? And what
yes, indeed, I will talk about the minimum prep technique, and I will compare it to the conventional one. And I will want to share my experience in this subject. I'll be presenting 2 cases and compare it to each other.
That's amazing.
Beautiful. Okay.
Thank you.
Just stop sharing and I'll get you the mic. The mic is yours.
Okay, let's start. I'll start to share my screen.
Yeah.
Go ahead.
Okay, we'll speak about the minimum prep, the advantages and the limitations too, and this technique. Okay, as I said, I'm Dr. Khalid Saeed. I work in Kurdistan of Iraq, in Duhok, and I had my professional diploma of implant, the first one in Erbil 2012, and then I started directly after this my professional diploma with Bear 2, the cosmetic one. And in 2016, I went to San Rafael University to get my diploma from there through Bear 2. I have huge memories and experiences with Bear because I always continue my education with them through the small courses and the symposium that were done out of Iraq. I'll start with just photo of one of my first cases. The last years has serious evolution in the cosmetic dentistry. The cases that I was really happy about 7 or 8 years ago when I done it, when I look back to it now, I feel that I can do much better now. Just like this case, even the photograph, the camera that I use, the flash, they always change. You can see even the angles of the photography is different, but it's not about the quality of photograph. It's about the quality of work that I was satisfied with when I began my career in cosmetic dentistry. And this evolution that I'm speaking about in the cosmetic dentistry, it's not only in the physical properties of the material we use. It's just, I don't mean we made it, and now that we have stronger material or we have high bonding strength to the veneers we use. No, I'm speaking about the optical properties that we have it now in our ceramic that we use for veneers. We have the aesthetic appearance is much higher because we can use multiple translucency. The ceramist now can achieve a nicer anatomy. They can do mamelons. They can do a lot of texture. And under the influence of the media, especially the social media, that affects our patients. We have to go on which path we should go with these patients that they saw a lot. They see many cases. They saw a lot of marketing to the cosmetic dentistry, and maybe they don't have the full image. They have maybe information that are not complete. So we should know how to deal with these patients. I'll start with the first case. The first case will be conventional preparation. When I will show it to you, I will explain why did I choose the conventional preparation in this case. He is a man, 20 years old. He is a student in university, and he has high expectation about the cosmetic result that he will have because he is watching always many photos that many good dentists sharing, like Dr. Thamer Deeb and others, and he's expecting something like this. the first step we do examination, but before the examination, I always have a long consultation visit with the patient. The aim of this long consultation visit is just for me to understand what the patients want, what exactly the expectation of this patient, what the type of veneer he thinks to have, how it will look. And I just check if I'm able to give him what he wants or his expectation are not real. The first thing to check with the examination when my patient on the chair, I want to check if this patient have parafunction or not. I check it clinically from the teeth, and I'll check from his history, because this will affect the whole treatment. The second thing, of course, the occlusion. We all know that the occlusion sometimes will prevent us from doing the veneers. Maybe we'll shift to orthodontic sphere or some crowns. And of course, I will check the caries and restoration that in the tooth, because we know that weak tooth or heavily restored tooth is not able to support veneers. When I look to the first photo, I will check here that the angulation of the front teeth of this patient, of the centrals, we see it's not straight, maybe it's 5 to 10 millimeters outward, okay, which is within the normal range. That means I can do veneers for this patient, because if it's very protruded, it's difficult for me to do veneers, because I need to cut a lot of the tooth structure, that maybe I will end up in dentine. Okay, we see here the occlusion is good. Otherwise, here the upper lateral almost is edge to edge, but it's not really difficult. I can manage it with extra prep here. Okay, now I'm showing my preparation. I'm not that type of dentist who like to smooth the teeth so much, because I believe that little bit roughening will help my bonding. Okay, we see here I did 1, 2, 3 crowns, the upper right 2 premolars and the lower right second premolar, because they already were root canal full teeth. So I choose to do crowns here, and we see the prep. Within the knowing that the enamel thickness in the gingival area is between 0.2, 0.3 millimeter, here in the middle almost 0.7, and the incisal third I have almost 1 millimeter. I know that my cutting shouldn't be within enamel. I shouldn't end up within dentine, because that will affect hugely the bonding strength of my veneers. So I did cutting from here, more than here, and minimum in this area. If you notice the lower anterior, almost I didn't cut in this area, in the gingival third, because I know that the enamel is very little here. I did a little bit cutting here, okay, in the interproximal area. I like to go a little bit within it, of course, without breaking the contacts. But why did I do the conventional preparation? Because I usually do less. That's what I'm explaining with the result. When you see the result, the patient had the smile that he wanted, and this something very nice. He wanted to look natural. I have keywords when my patient just mention it, that I get to understand what they mean. Just like when patients say, doctor, I want natural smile, that each tooth looks separate from the other. I don't want my teeth to look just like denture connected to each other. I know that they mean the interproximal area between teeth, it should be deep. Because when it's deep, it's like this. We can notice here in this photo, central, lateral, they have very nice emergence profile. Okay, this emergence here, that will give this impression. When you see it, you feel they are separate. Because if I didn't do a good clearance here in this area and this area, they will look just like they are packed together, the teeth. So one tip I want to share, that when I want it to look natural and separate, I have to go there. The second thing, I always, in the consultation visit, I share cases that I did with the patient, and I see what exactly they want. And this patient, the cases that he liked, the high translucent cases, and he liked when he look at it to look vital. We know that vitality of the veneers just depending a lot on the translucency, and translucency needs space. The original shade of the patient teeth, we can see it here, it was all A3, and we managed to give him bleach 4. Okay, so he wanted to be white, but not really white and look natural. If we see in this photo, I could mask the original shade, and I could give him a very translucent area from here, from in the middle and the incisal third, and that needs space because I have to use multiple layer in this veneer. The first layer will be low translucent to mask the original shade, and I should pack the other layers to give him this translucency. We can see from here to here. In the lower, we see the translucency in the slit, in the gingival and middle third, and there is a gradual in the shading of these veneer, which looks natural, because I couldn't take the risk in cutting here in this area, but it looks natural too, because this is gradual. If we discuss the details of the veneers that my patient come, because I'm doing lately a lot of cosmetic cases, more than I done before. Before I was mostly doing the implant cases. Now my career is shifted to cosmetic. When we discuss the details with the patient, we will be surprised by the information they know about the details. Just like many patients will understand this translucency, and they like it. They say, "Doctor, I like it to be like this." And even they could have some idea about the mamelons when they check photos, because I work in small city, but my patient, they come and they have ideas about doctors from all the world, and they had seen their work and they just share it with me. So I could understand this patient wanted his teeth to have high translucency all the way. That because the photos that he chose, it was like this. He wanted to be natural like this. So I knew that I need space, maybe 0.5, 0.6 millimeter in this area, that to pack my veneers. Already the patient teeth was 0.5, maybe 5 degrees outward. So that means if I'm just adding material, it will be bulky, and usually male doesn't like this. If we see here this photo, we will notice obviously this translucency and how it's gradually become less and less and less till it's got here, which is natural, just like the animal, because it's less in the gingival than the incisal. And for the last photo for this case, when I see the profile of this face, I see that the veneer here in the central is almost straight. It is less than the original status, especially male. They don't like protruded teeth. And in general, in veneer, when it's like this straight, the surface, okay, it will look more natural, and the smile will be nicer. So always I avoid to have this angle just coming outward, and the veneers. I try to make it as straight as possible for males, especially like this. So I did cut here in the incisal third more than I cut from other surfaces, but of course it should be all within the enamel. After this case, after we did it, finished it, the patient was happy. But to be honest, the biggest challenge in this case, it wasn't that I am I able to give the patient his expectation, because when I discussed it with him, they were realistic, they were achievable. But the biggest challenge for me with this patient, that convincing him that I need to give him anesthesia, I need to cut from his teeth, I need to put temporaries for this patient, and especially under the influence of marketing for the prepless veneers, that saying you don't need to have anesthesia, you don't need to cut your teeth, just we'll put it on your teeth. I should explain for this patient that the result that he's asking for, that the style of a smile he's asking for, styles of the color he wants, is difficult to be achieved without preparation. Okay, especially as we are as dentists, many of us still think that without preparation of teeth, the porcelain margins, they will be detectable, they will be inappropriate, they will be cause unhealthy tissue, soft tissue, they will cause us gingivitis, they will cause poor emergence profile. But indeed, this is not true. The reality is the prepless veneers, when managed properly, can give us biologically and optically beautiful margins. It can give us a nice profile margins. We can know this from the recent literature, not the old literature, because the new prepless veneer can be done from more than one material, just like the feldspathic or the lithium disilicate. Me personally, I prefer the lithium disilicate. Now the case that we see was done prepless, almost zero preparation for this patient. We can see here the margins gingivally. It looks healthy. The emergence profile interproximally and gingivally, they look healthy because this was done from the lithium disilicate for very, very low thickness. It's almost 0.3, 0.4 millimeter. And we can manage here gingivally. We can manage this this area with the bear. We can just smoothen it with the bear if you feel any margins that are detectable. So the patient will have healthy gum. If I want to compare this to the other case, of course, we are as dentists. We see that the older case is more, the first case is more pleasant aesthetically because he has many shades. He has a gradual translucency. He has mamelons. Of course, I managed to give her a little bit this translucency. And of course, the all ceramic is translucent, but not high translucent because I need to mask the original shade. This patient is A2 and I managed to give her bleach 4. But I did this after the consultation. All my decision for the both cases, they are both not old cases, maybe 4 or 5 months ago, but both of them, I took the decision to do the mini prep or non-prep veneers or just the traditional preparation after the consultation. Because in the recent case, the most important point for this patient, she said, "Doctor, I want to have nice smile without cutting my teeth. I don't cut my original teeth." And after checked it, we see spacing case, which is perfect for prepless, and her teeth were straight. So it was a good option to give her this type of veneers, the prepless veneers. If I'm getting back to my first case, could I give him this patient prepless veneers? I couldn't give him totally prepless, but if I wanted to do, I could cut a little bit here. Okay, just in this area, maybe 25 preparation of I did, and I could give him some veneers like will look not like these veneers, but will look like these veneers. Okay, but the question, will my patient be happy if I gave him such veneers? This is the main question that I was asking myself. Of course not, because the consultation visit, the long consultation visit, the detailed consultation visit, that's the use of it, that to understand what's my patient want. Because I will show now the last slide, which was for a patient. She came from Europe and she wanted to have veneers, and the upper left canine was missing. She wanted to have implant here. I did for her immediate loading implant, and I did veneer, and I gave her the option to do the prep veneer or prepless veneer, and she was asking about the difference. She said, both of them, how is the aesthetic result? I said, for both of them, I will give you the same smile design. Both of them will look beautiful. Especially she has a spacing here, so in this area here, I have a space, so I wasn't worried about the interproximal area to look natural. And I told her you can choose both of them the same shade. On the try-in, when I tried her veneers, she was very happy. She said they are very pretty. Just that was I was dreaming about. After I fixed the veneers, she was happy too. But in the next visit when she came, she said, "Doctor, they are beautiful, but they are not like my cousin's veneers." Her cousin came to my clinic, and I gave him prep veneers with higher translucency. Of course, in this veneer, we can see the texture. I will never do flat teeth because they will look so much abnormal. Of course, these veneers are white, but it was the patient option that I couldn't adjust to have this shade because I don't like the white veneers. She liked the color, she liked the design, but and she said, I expected something more vital. I expected more translucency. So in this case, my mistake was that I didn't explain the details of the veneer that will come out. Even if we do wax up, if we give temporary, the temporary will never show the translucency. Even the real shade, the translucency will never show it. So my message today to all dentists, our patient, they know a lot more than we expect. So just we should respect this knowledge, even if it's incomplete knowledge. And we should discuss the small details. Yeah, sometimes even me, before, I thought if I'm doing wax up, I'm doing mocha for the patient, and I just did that means I will miss their expectations. But now they know about small details like the texture. Maybe they don't know how to explain it for us, but if we show them the photos that we do and give them the options to choose, we can give them the result that they really need. Thank you.
Thank you, Dr. Khalid. That was beautiful.
Thank you.
I love your cases, and I love what you said about the consultation visit and how important that is. So, beautiful case. Well done. If anyone has a question, please type them in the Q&A box. I had great shout outs to your photography, and a lot of actually one of the questions is about what type of flash do you use during your photography?
I use the softbox. I use two softbox and use the professional camera, of course, Canon or Nikon with 100mm lens.
And do you use contrasters or?
Contraster. When I took the intraoral photos, yes, some photos I use the contrasters, yes, like these photos.
It's beautiful.
Thank you.
No, honestly, amazing.
Okay, Mohammed, I would like to, I love your take-home message. Respect your patient knowledge and intelligence, because you're 100% right. Our patients now much more educated than what we think they are. And my question to you, how do you think our patients developing these high expectations, and why they're developing these high expectations from your experience?
And indeed, it's partly our fault, the dentists. Maybe many of us have pages on social media, or just we are showing a TV show. When we speak about cases, maybe we show our best. Of course, if I want to post one case a week, I will post the best one. Just like the case that I posted for a prepless veneer, it looks very nice, but maybe the patient will come to my clinic and he has protrusion in his teeth and he has carious teeth that need to be crowned. I said, do for me prepless veneer. Doctor, you said you can do prepless veneer, or just you can give me this translucency without cutting my teeth. I think we need to explain more, which is difficult to explain on TV show or on our pages on social media. Sometimes I do short videos trying to explain this, but maybe other dentists, they just, maybe some just caring only about showing the final result, which will affect the mentality of our patient. That's why we need long consultation visit. Just show the patient photos. They don't know to say what is mamelons. They don't know to say, I want texture, I don't want flat tooth. Okay, but we show them close-up photos. We show them videos of our patient when they're speaking and smile. They will say, yes, doctor, I like this and I don't like this.
Mm-hmm.
I noticed, Khalid, when you do veneers, you tend to do more than 6 teeth. Or how many teeth ideally you like to do when you have a case?
10.
Isn't my other question, when do you draw the line between over-treatment and under-treatment?
Okay, we are working in the Middle East. Middle East, usually patients tend to ask for whiter teeth. When I do just like 6 veneers, okay, when my patient smile, of course, minimum he will show the first premolar. Okay, or most of them will show the second premolar. Usually I do the premolars prepless. I don't cut a lot, so just I don't think it will cost the patient only economically to pay more, but it will not cost him to cut from his teeth, from the premolars. The case I showed, it was crowns because they were already root canal filled. with heavy restorations. So that's why we did crowns. But usually when I do veneers for the premolar, I don't need to cut from them. I just will add surface. Even if it's not really translucent, only the same color, it will look nicer. That's why I like to do usually 10 or 8.
There is another question that there is a photo in the background.
Yes, which photo?
Let me tell you right now. So.
You mean this photo now I'm showing? I'm sharing now this photo or other one?
Yeah, I think that's the one. That's the one that everyone are trying to figure out how to make that beautiful photography.
Yes. Firstly, I want to say something. If the veneers are not very translucent and have enough thickness, they will not look like this, even if you are using any system of photography. Okay? The second thing, I just, as I said, I use the two soft boxes. I'm trying to keep them close to the patient. Okay, not like when we are taking a smile photo. We can, and I use the contraster, the black one, and it needs experience. I couldn't take such photos maybe 3 years ago, but when you take multiple shoots, you know the angle that will showing what you want to show. Of course, these photos are not edited. They are originals photo. I don't try to play with my photos, but I should know which angle will show the translucency, just like here, the mamelons. And this photo, I took it a little bit from it's 12 o'clock. Okay, so I showed the gradual shade here. It looks more, the shade is gradual from here to here than this photo. The mamelons here are more obvious, okay? The translucency here. Here I show the interproximal area. I want to know what I want to show, then I have to try it more. Maybe usually when I do such, I take 100 photos for the patient. It's exhausting for patients.
Of course. And do you tend to show your patients photos beforehand, something that you've done before? Because I've noticed that you said that she was unhappy because her cousin had better.
Yes, indeed, her teeth. For me, I see the smile design is nicer, especially she's female. Usually, female have nicer smile than male after we finish the treatment. The design was nice. The implant was very good for her, but the problem that I didn't know that she will focus on the translucency. Of course, with the prepless veneers, I will give her a translucent veneer, okay, but medium translucency. If I want to give her like this photo mamelons, I had to cut from her teeth and make them shorter. So I couldn't expect that. That's why now I'm doing
Khalid,
longer. That's
for how many patients in percentage do you think we will be able to give our patients non-prep veneers?
Okay, if we are talking about 100% non-prep veneer, maybe 20%, 10 to 20, I'm not sure.
Can I disagree with you?
Of course, why?
Yeah, because I think if we do it in percentage, the only cases you will be able to do totally prepless or not, we are not talking minimal prep or micro preparation, but when we say prepless, prepless at all, or maybe minimal finish line, okay, this cannot be applied for more than 3 to 4% of the cases.
I do a lot of prepless cases. Maybe sometimes the edges. Yeah, when I cut from teeth, just like this.
It's not about how many cases we do in this direction or in this technique. For example, if I will rely on cutting the veneers to do the final polishing, okay, this is the most dangerous thing we can do for the ceramic material first, okay, because when we take this polished surface, just using the burr and trying to mechanically polish it, first of all, is not always successful. The second thing, it might induce more gingival inflammation. The idea, I agree with you, we can do prepless veneers, we can totally do no preparation, zero preparation veneers. They do not look exactly like the prepped veneers, but okay, you can do it if you have small teeth, if you have retrocline teeth, but for a 90-95% of the cases, you just cannot do it. The idea is nowadays most of us or most dental clinics, they advertise prepless veneers as the common treatment, as the common usual, okay? And this is a big problem to other dentists, because you have the patient insisting on having a prepless case or prepless veneers, and you know this is not possible because of his teeth, because of the alignment of his teeth. But the media, the television is all over prepless veneers, prepless veneers. We are more focusing or selling this to patients without, for example, if you buy a pack of cigarettes, you will have a warning tell you this might cause cancer or this is unhealthy. I think for the advertisement of no prep veneers, we should add like a sign that this is applicable in only 2 or 3% of the cases, because this is giving us dentists more pressure. The amount of media, the amount of advertising on prepless veneers, this is giving us more pressure to do such kind of treatment, though I don't think it will be applicable to more than 2-3% of the cases.
I think
Great job, Khalid. Great job, Khalid.
Thank you, Doctor. I agree with you, but you know, the same case that I did with the preparation, I could do it with much less preparation if I'm using thin veneers. And that's what I'm trying to say. Just let me see my patient prefer. I do many cases with mild preparation, micro preparation, but of course I don't give them the same result like the photos that most dentists like. So that's always what I'm trying to say. Maybe I will need 10 or 20% of that preparation that I usually do if I will give them extra thin veneers. But of course, I cannot layer it. I cannot give it the same texture. So I always give that choice to my patients. I see what he prefer. He prefer to have this luxury veneers if it's true this term, or just have veneers which look nice but much thinner and conserve the most quantity of teeth that I can conserve. But I do in most of my cases now, I don't need anesthesia. Just I cut when I check the case, I see if there are protrusion in some teeth, I just align it and I take impression, I give him very thin veneers. And indeed, really, I need to adjust it with bare eye that I was said. But usually, this new veneers, they're very thin, even the margins, that I really need to adjust it. But if I feel there is some place the margin is not thin, I can adjust it with bare, but it's not something usual that I do it for all my cases.
Khalid, it was an amazing presentation. And what I liked in your presentation, it was honest. You showed us the limitations of both techniques. And I think the message between you and Tamer is a clear message that it's all about patient selection and being clear with the patient from the very beginning about limitations of each technique. Thank you very much, Khalid. And
great, Khalid. Great work, Khalid.
Thank
Great cases.
To all
Nice
our
results.
friends in Kurdistan.